Good morning, everyone. My name is Alfonso Ielasi, and I'm a consultant interventional cardiologist at Ospedale Galeazzi Sant'Ambrogio, Milan, Italy. It's a great pleasure for me to be here today and share this very interesting webinar on CTO and CHIP PCI, insights from the clinical practice. With me, there are several experts which will give us some insights on the treatment of complex patients and lesion subsets. In particular, Dr. ZhanYing Han, director of the second ward of the Department of Cardiology of the first affiliated hospital of Zhengzhou University, China. Dr. Miha, medical director of the coronary care unit at the Department of Cardiology, University Medical Center, Ljubljana, Slovenia, Europe. Dr. Sohail Q, consultant interventional cardiologist at Queen Elizabeth Hospital in Birmingham, UK. Dr. Lucio Padilla, interventional cardiologist at Instituto Cardiovascular de Buenos Aires, Argentina, South America, and Dr. Şevket Görgülü, professor of cardiology at Biruni University School of Medicine, Interventional Cardiology Department, Istanbul, Turkey. So in the next minutes, we will discuss about very interesting topics, in particular bifurcation, PCI, complex left vein PCI, and CTOs. As you know, technical and technological improvements allowed us as interventional cardiologists to tackle very complex situation every day. So in the next minutes, I hope we can share very nice presentations and we can discuss about important topics. So please, Dr. Miha Čerček, start with your presentation on optimizing bifurcation PCI. Thank you.
You?
Yes, we can hear you.
Okay. Thank you for the introduction. My name is Miha Čerček. I come from Ljubljana, as you mentioned, Slovenia, Europe, and I'm here to talk about optimizing bifurcation PCI, presenting a case that you may see in everyday basis. So this is not something that would be reserved for cheap operators or anything like that. So let's just go ahead with this case. I'm presenting a case of a 46-year-old male. He was a truck driver, previously healthy, with no prescribed medication, and he was a heavy smoker, though. And he presented with chest pain occurring 1 hour before admission. In the EKG, the anterolateral STEMI was evident, and upon the arrival of paramedics, there was no physical examination abnormalities evident. And he was brought directly to our cath lab, where we performed coronary angio. And as you can appreciate on this slide, on the left-hand side, right coronary artery is normal, and there is a lesion, a significant lesion in the first diagonal branch, and also a sluggish flow down the LAD. So first, we directly stented the diagonal branch, which appeared to be the target lesion, getting a nice result, but still there was a slow flow down the LAD, and there was a bifurcation lesion at the LAD diagonal level. So we decided, we didn't know at first how to just medical treatment suffice. So we decided to perform OCT imaging to see if there's any palpate plaque or a ruptured plaque at that site. And there was no rupture noticed, but there was a significant stenosis at the level of diagonal ostium, as you can appreciate on this middle part OCT image. Therefore, we proceeded with the bifurcational stenting. Double two-stent technique was used because there was a lesion in both the reality and the diagonal ostium. Of course, you can decide on which technique you want. There are several very well known and described. In this case, we wanted to stent the diagonal branch first because there was also already one stent there, so the tap stenting technique didn't come to our option as an option. Then, of course, culotte stenting or crush, any of the crush techniques would seem appropriate, and we decided to go on with the mini crush. Of course, the most evidence are present for the DK crush technique. However, we wanted to avoid excessive dilations of these acute lesions, and mini crush techniques, there's one kissing less, so that's why we chose that technique over the DK crush. There's also a nano crush technique being described, but it's difficult to perform. So as you will see, mini crush was done. First, we stented the ostium of the diagonal branch with a 2.5 times 15 millimeter drug-eluting stent, and then it was crushed with a non-compliant balloon, and the LAD was stented with another DES drug-eluting stent of 3.0 times 22 millimeter size. And this was the result as shown on as checked with the OCT. You can appreciate there was the second stent was not nicely opposed, and so we wanted to check with if the wire was through the right strut, but the OCT didn't give us the right resolution, and it seems to be through the distal strut. So then we continued with kissing inflations of 2 non-compliant 2.5 balloons, and at that bifurcation, and finalizing this procedure with proximal optimization using the pod PTCI balloon of 4.0 times 6 millimeter size, as you can see on this picture. The final result was very nice. There was a rapid STIMI3 flow in both branches, in the LAD and the diagonal, and as you can appreciate on the OCT, the stent was appropriately expanded and well opposed. So just a few slides about this proximal optimization technique before I finish. This part of the procedure, which is often overlooked, is critical in both provisional and two-stent strategies to ensure both proximal strut expansion at apposition, which is crucial to avoid abdominal rewiring, and it's also important to open stent cells across the side branch, facilitating the side branch recross. So it's an important step, but often difficult to perform appropriately, because if you want to perform it correctly, then you have to place the pod balloon, as shown in this middle part of this schematic, at the carina, and reaching all the way to the proximal part of the stent. In this way, you get the great stent expansion and appropriate apposition. If you put this pod balloon too proximally, as shown on the left-hand side, then you risk proximal stent, proximal at edge dissection, and in addition, incomplete expansion at the side branch ostium. On the other hand, if you put the pod balloon too distally, as shown on the right-hand side of this image, then you risk distal main vessel overexpansion, causing carina shift and obstructing the ostium of the side branch. And in addition, proximal stent malapposition, creating bottleneck shape of this stent in the main vessel. It's often difficult to perform this procedure correctly because the regular non-compliant balloons have a rather long shoulder length. It's around 3 millimeters, and it's difficult to put them precisely at the carina, because often you reach too distally, or if you're too conservative, then you put this pod balloon too proximally, causing the problems as I just shown. There are these special pod balloons that we used in this our case, pod PTCI balloons from BrosMed, which have the shortest shoulder length on the market, only 0.6 millimeters, and are really easy to position, or much easier to position at the correct site at the carina. And this is another image showing this nice position of this balloon at the carina, but much more difficult so with a regular non-compliant balloon, because it reaches much more distally because of this longer shoulder. So to conclude, pot PCI balloon in bifurcation stenting minimizes carina shifting because you can put it directly where you want it. It reduces high pressure stress in not needed segments, optimizes pulse dilation, and prevents high pressure trauma outside of the stents, which is very important to avoid proximal edge dissection. So this is the end of my case, and I thank you for your attention.
So thank you very much, Miha. It was a very nice and interesting case highlighting the importance of the pot balloon in the setting of bifurcation PCI. So I invite Dr. ZhanYing Han to comment on the case or to share some insights.
Okay, thank you. And nice to meet you. It's very excellent presentation for this patient with bifurcation lesion, especially in the STEMI. This patient is just a 46-year-old male patient with STEMI, and you can see the target lesion is the LAD and diagonal 1, and the flow flow. This patient has the slow flow, and then how should we treat these bifurcation lesions? And Dr. Čerček and choose a mini crash strategy. And I think, and my question is, and maybe because the small size of the side branch of the diagonal 1 and just the predilation using the small balloon into the LAD and diagonal 1, maybe using the, you can see this, according to the result of the OCT, there's much more thrombosis. It's the local of the orifice diagonal 1 and the LAD bifurcation sites. Maybe how do you think of the DCB to treat the side branch and using one stent crossover to treat the LAD bifurcation? Okay, thank you.
Yes, that's a great comment. Thank you. Of course, we could go with this leave nothing behind strategy and you only use drug-coated balloon for this ostium. However, we already put one stent in the diagonal because there was what seems to be a target lesion. But yes, even if we chose this one stent, provisional stent strategy for this bifurcation, we would still need to perform this proximal optimization. And again, the same, everything goes using the correct size balloon and positioning it at the carina. It's much more easier if the shoulders are shorter with this non-compliant balloon.
Yes, you're choosing the very short shoulder balloon to do the port techniques, and we have this very good result. And compared with other balloons, and choose a much more size balloon and 1-to-1 into the proximal of the lesion stents, and using the very relatively correct pressure to treat it. So, and congratulations.
Thank you.
Are there any other comments? Okay, so personally, discussing about DCB in this setting, to me, it is not the best spot, thrombotic lesion in the diagonal branch, because the drugs cannot be fully transferred to the vessel wall, probably. In such a situation, I would go for the simplest solution, the simplest option. So theoretically, a single stent going from the LAD toward the diagonal, then trying to recross the LAD and opening the vessel to the mid and distal segment, and let's see if it is needed to stent approach as a bailout, because personally don't like to go with 2 or 3 stents in the setting of acute coronary syndrome in order to reduce the risk of intraprocedural or periprocedural thrombosis. But you showed a very nice case in terms of management. Probably at the beginning, it was not your aim to go with a 2-stent approach. but then related to the carina shift, it was needed, and finally the POT balloon was really useful to optimize the result. And in this kind of situation, it is mandatory to have an optimal result at the end to avoid acute complications, particularly stent thrombosis. So if the other speakers have no comments or no questions, I will move forward to the next speaker, Dr. Sohail Q. He will show us a case or a presentation on complex left main PCI. So please, Dr. Q. We cannot hear you.
Yes, can you hear me now?
Yes,
so
now we can.
Thank you.
Yes.
Thanks, Alfonso. It's a great pleasure to be here and join you for this wonderful webinar. So, good afternoon, good morning, good evening, wherever you are around the world. So, I'm Sohail Q. I'm an interventional cardiologist. I'm also based at the University of Birmingham. I work at the Institute of Cardiovascular Sciences. So, I'm going to share with you a case about a complex left main stem, which I think has lots of discussion points within it. So if we move to the next slide. Okay, so this is an 80-year-old gentleman who has a background history of high blood pressure. And he came to see one of my colleagues because he was getting symptoms of typical angina despite being on medical therapy. You can see he's also resistant to statin therapy. He was only on pravastatin. He couldn't tolerate any of the other statins, and he was unable to take a beta blocker. And the nitrate that had been prescribed for him was giving him profound headaches, so it was really making his life quite difficult. Hemoglobin was very reasonable. EGFR a little bit on the low side, but not bad for an 80-year-old gentleman. So in view of his ongoing symptoms, he came forward for an invasive coronary angiogram. I've got some key images which are running here. You can see that he's got tight left main stem disease, but also extensive calcific proximal LAD disease extending really to that second diagonal, so involving the mid LAD segment as well. Now, on the other views, just before the contrast is injected on the left-hand side, you can see the calcification, tramline calcification within the vessel. The spider view is actually very important here because it shows you that actually most of the circumflex is unaffected by this atheroma. There's a very tight osteostenosis in that LAD segment. So at this stage, he was taken off the table, really for a sort of informed discussion with him, but also his family members. And we presented him at our MDT meeting with our surgeons. And the surgeons actually quoted him a surgical risk of around 2 to 3% for any major adverse cardiac event. When we did a syntax score, the syntax score was falling in the mid-range. This is, of course, a dominant circumflex, and more than likely we are going to need to do some form of calcium modification given the heavy degree of calcium within the left main stem proximal LAD complex. So after all of this was put to the patient, interestingly, the syntax score was also giving him a syntax 2 score was giving him a MACE rate of around 1.5%. The patient was quite keen to be treated quickly, but also was keen for quick recovery after the procedure as well, and therefore opted for PCI, which I think is not unreasonable given the coronary anatomy that we saw. So this was a case actually only performed last week in our cath labs here. So on the left-hand side, you can see I've gone with a 7 French guiding catheter, knowing that we're going to need to do some form of calcium modification in that left main LAD. It is a dominant circumflex, and the first difficulty that I encountered here was that as soon as the guide went in, I was getting a lot of damping of pressure here. So I was able then to quickly put the wire down into the circumflex, which allowed me then to back out my guiding catheter. And then on the right-hand side, you can see I've taken a dual lumen microcatheter, which then allows me to wire into that LED complex, because it was proving quite difficult with a single lumen catheter to actually get a tip on, which allowed me to get into that LED. So on the left-hand side, you can appreciate that actually wiring was a little bit tricky. The wire was getting caught up in the calcified proximal LED segment, but with some manipulation, I was then able to wire down into that distal LED. And then I switched out, knowing that this is heavily diseased vessel. I went for an upfront rotablation strategy here without any imaging, because I didn't think my imaging catheter would be able to traverse that very tight proximal LED lesion. So I switched out over a single lumen microcatheter to a rotor floppy wire. So I'm not going to show you all the burr runs here, but essentially I performed 3 burr runs, the very proximal left main LED complex, and then dynaglided into the mid LED to perform further rotablation in the mid LED segment, ready to ensure that we've got adequate preparation of the vessel. Now, unfortunately, at this stage, he started to develop quite profound chest pain and dropped his blood pressures. Systolics started to drift down to around 80 systolic. And you can see what's happened here. 2 things really. We've been quite unlucky, although we were meant to get differential cutting with the rotablator device. You can see what the rotablator has done is it has effectively dissected the distal left main stem. So we've started to get slow flow into that circumflex, but also we've probably got some element of no reflow in that LED as well. And being a dominant circumflex, this is providing around 80% of blood supply to his heart muscle. So very quickly, I was able to take a second wire. You can see I've wired into this high OM branch, really just wired whichever vessel was available to me at that time. So high OM branch, with a plan then to think about further preparing this vessel with a view to stenting that left main stem. So I did in fact take the stent, but actually putting the stent down, I was getting a lot of resistance in that proximal LED section. Therefore, I felt that I had to do some ballooning, and you can see he's not liking this very much. He's got his left hand to his chest, and his blood pressure is really quite low at this stage. So the priority really is to get the stent in as quickly as possible. And my strategy here was really just to take a stent from the left main stem and tack up that dissection in that proximal LED section as quickly as possible. So fortunately, I work in a dual imaging lab, so we've got a dual picture here simultaneously. So LAO RAO caudal view, which shows that actually nailing the ostium of the left main stem. This is a 3-5 stent, probably too big for the LED itself, but you have to be cognizant that you're going to want to oppose this stent to that left main stem, which is probably a 4.5 vessel in its entirety. So the stent was then successfully deployed, and then here on the left-hand side, you can see I've used the stent balloon then to post-dilate, and what you can probably just about appreciate is that this stent balloon is probably more distal than really what it should have been. And the reason for doing this is, of course, I want to oppose the ostium of this left main stem and not have my guide catheter interfere with that left main stem, because those stents are going to be unopposed in that very proximal segment if we don't perform this maneuver. So unfortunately, this then led to a worsening of the situation. So although I've rescued the left main stem proximal LED, we start now getting slightly sluggish flow in that circumflex. And he started dropping his heart rate as well. And I think what's happened here is that he's ended up with a carinal shift of that proximal LED lesion into that circumflex, which is why we now have TIMI1 flow in that section of vessel. So, sorry, let me just go back one slide. Yeah, so schematically, let me just show you what this means. So of course, when you're stenting across a side branch like we have done here, very important side branch, what you really want to do is to ensure that you have proximal optimization. This is what the guidelines now suggest. This helps you in two ways, really, because it allows you access into your side branch, opening those stent struts into the side branch, making access a lot easier. Not doing this, of course, risks your wire going behind the non-opposed, very proximal stented segment, which can lead to stent deformation. So the next maneuver that you see here on the imaging is me then performing proximal optimization here. And we've seen this image already from Miha this afternoon. The advantage of the pot balloon is that, of course, it has very low shoulders to it, so it ensures that you're able to not get involved in the complex bifurcation, particularly that circumflex side branch. If you were to take a regular balloon here, what normally tends to happen is that if you position your markers adequately, you invariably will have a shoulder hangout, which can then compromise flow in that circumflex either further. So this is a wonderful balloon. We've been using it now for a long period of time. It's low compliance and it folds really easy. And that's important because, of course, you always want to end up finishing with a repot often in cases. So here, that allowed improvement in the flow into the circumflex. Remember, this is a jailed wire here, but I was able then to negotiate a third workhorse wire. Of course, what you want to do is probably to ensure that you have correct crossing. You probably want to ensure a distal cross here. But here I was happy to take whatever access was allowed into that circumflex because his blood pressure, as you can tell from the contrast hold up in the ascending aorta here, was very, very, very low. Now my strategy here was now ready to think about sort of modified tap, really. I didn't have time to put my second balloon into the LED. Really wanted to rescue this vessel as quickly as possible.
Am jeszcze lubię mam este stare după Jack. După Perșout, eu văd Fabian.
I think we had some issues with the audio because I can hear you well.
Особено бен разбал. Пишу там до играе, попусат не дал, да не поура.
I'm hearing some other voices, but not the speaker.
Yes, apologies for that. I think we just lost connection there.
Yeah, probably some interferences.
Yeah. Okay. So I don't know how far we'd got. I'd wired the circumflex at this stage, and on the next image you'll see. Is it being shared with you now? There we are. So on the next image, what happens is that we manage to restore flow into that circumflex complex. But of course, what we haven't done here is optimize the stent in the LED. There was also a dissection that we picked up in the mid LED, probably where the rotaplator had been, and probably slightly oversized stent in that proximal LED segment. So I performed a KISS balloon here, really just to reconfigure that proximal LED segments, a pair of 3.5 non-compliant balloons. And again, after that, it's very important then to do your repot. And as I said, it's a very deliverable and refoldable balloon by the BrosMed. So we're able then to reuse that balloon to optimize that section of vessel. So these were the final angiographic pictures. So we got a lovely result in the left main stem, circumflex, proximal LED, having to bail out with a tap. I was able to perform a intravascular ultrasound here. So we did a run coming back into that LAD left main stem complex. And what I really want to sort of point out is well-opposed stent struts in the LAD. But as we come back, what you'll appreciate as we come back to the bifurcation is the circular nature of the left main stem. And this is because we've used this lovely pot balloon to really optimize that stented segment in that very proximal segment. So here we are, you see this lovely circular image, and actually your minimal stent areas here were above 13 millimeters squared, and we know that's associated with a very low restenosis rate. So just to sort of conclude, this was a challenging rotablation case in a dominant left circumflex system. The proximal optimization has been proposed as a method to try and improve stent scaffolding, particularly of bifurcation lesions. We know that if it is not done properly, then you can risk carinal shift compromising your side branch. In this particular case, we were able to use a dedicated pot balloon to ensure that we had correct placement just proximal to the carina, and the IVUS confirmed that we had a lovely result with an oval-shaped left main stem. The patient did very well and was successfully discharged home the following day. Thank you very much.
So, very nice, very interesting case. I think there are many points to be discussed, but again, you highlighted the importance of having materials such as the pot balloon manufactured by BrosMed in order to optimize the result at the level of a complex bifurcation. In this case, it was a calcified ostial LAD. So the point is how to manage that kind of lesion, imaging pre or not. I guess that probably imaging would have been a very nice step before to decide the size of the rotational burr, because of course it is well known that performing rotational atherectomy at the level of a bifurcation could be complex, because in most of the cases a wire in the side branch is not placed. So in case of oversizing of the burr, complex dissections can occur. You were very, very good in order to manage this kind of complication, but sometimes the evolution of the case can be also very different. So thanks a lot again and congratulations. And I invite Dr. ZhanYing Han to comment the case and to provide some insights on this very complex and nice case.
Okay. Thank you for give us this very excellent presentation about. I think this patient is very dangerous and very unfortunate during the first step. And for patients with left main bifurcation, and the first step, maybe we should evaluate the risk of the treatment and compare with CABG between the PCI, and according to the syntax, usually we are according to the syntax score, and this patient maybe is mid-range, and I think it's about between the 22 to 32. This patient, so you can choose the PCI or choose the CABG, and both strategy is okay. And because of the very serious calcification at the ostium of the LAD, then choose the rotablation. And I think rotablation is very, very useful for this patient because it can minimize the plaque burden, especially the calcification plaque burden, and can help us to obtain very large lumen of the LAD and change the angle of the angle between the LAD and the left main. And unfortunately, and after the first step, sometimes it's very, very difficult to draw wire to the LAD because the acute angle between the LAD. Sometimes it's very difficult to wear the circumflex. So, and a doctor, Kohan is very excellent operator, and with the help of the microcatheter, and using various software, sometimes XTA or XTR, and sometimes using the reverse wear into successfully wear to the LAD, and then immediately after the root ablation of the LAD, this patient has very serious complication into the slow flow and dissection, maybe. And if we can quickly treat this complication, this patient may be very bad result. So crossover, one stent, recover the flow to the LAD, and so in this step, maybe we should use a port, the very short balloon, and to port the orifice of the stent, then and can avoid the guide wire and go behind the struts sometimes, and can change the deformation of the stent. So we use after the port step, then rewire to the circumflex, and using the provisional strategy, and deploy implant another stent to circumflex, then kissing balloon, and report the orifice, check with the iris. So I think this patient will have a very good long result. So, and my question is, how you could predict this slow flow or dissection for this patient? Thank you.
Yeah, no, thanks for your comments. I think, it's always tricky to know which patients will end up with no reflow. But we know that there are predictors. Long burr times will increase your chance of getting no reflow. We know that there's an association with amount of plaque as well. So if there's a large plaque burden, then your chance of having no reflow is higher as well. I'm not aware of any upfront techniques to actually reduce the risk of no reflow, but when it does occur, there are certainly options in terms of administration of pharmacotherapies, particularly adrenaline, which has now been shown in a small randomized controlled trial to improve no reflow in comparison with adenosine in a head-to-head study. My strategy here was always to do an upfront single stent approach, and I wasn't really planning to get involved into the ostium of that circumflex, which looked actually undiseased on the initial angiogram. My concern about putting the IVUS down, I take your comments on board, was that this was heavily calcified, and I'm not sure without ballooning that I would really have been able to get an IVUS probe down into that proximal LAD segment because of the tight stenosis. And what I didn't want to do is then lose my ability to perform rotablation if I ended up with a dissection after performing ballooning in that proximal segment. And that's why I went for an upfront rota strategy here.
Well, yeah, at least in my opinion, for sure, probably the IVUS probe or the OCT could have not been able to cross the tight lesion of the ostial LAD, but probably a soft predil would have been of help in order to avoid this kind of dissection, because in my opinion, it was not a slow or no reflow, but it was a flow limiting, very extended dissection toward the LAD and the left circ. So you were very, very good to manage this kind of complication. So the question is, do you suggest, based on this case, techniques to protect the side branch of the bifurcation in case of rotational atherectomy on the main branch? I mean, there are some descriptions of two guiding catheters techniques in order to protect the side branch using a microcatheter and a wire, and then do rotational atherectomy on the main branch. So do you think it is something safe to be performed in such a case, particularly when you have a very tight ostial LAD or left circ lesion? So first point, and the second, the second point is, why not try to fix immediately this very complex and potentially life-threatening situation with a two-stent strategy, a quick two-stent strategy? I mean, mini crash or SKS, because the patient was going to be hypotensive, I suppose, so no mechanical support, because that was not the plan at the beginning. So why go for a single stent strategy in such a situation?
Thanks, Alfonso. So yeah, I think you're referring to my case report that we published in European Heart Journal not that long back, talking about ping pong guides and protection of the side branch with a microcatheter. So we've got extensive experience of this. We've tried this off the patient as well. So bench testing using both Caravel and the Corsair microcatheters. The trick is to ensure that you move your microcatheter a few millimeters proximal or distal as you're performing this technique. The downsides is the procedure does take longer. You end up having to get a second access to be able to perform this. There is another slight variation of that technique where you can use a guide extension catheter, such as a 6 French guidezilla, to be able to protect, but then you need an 8 French guide to be able to perform that. So yes, that is useful technique. It's particularly useful if you've got disease in both vessels and you don't want to lose access to the second branch. I have to say I wasn't envisaging any issues or problems here. As I mentioned, there wasn't any disease on the angiogram on or within that circumflex, proximal circumflex segment at all. We were dealing predominantly with an isolated proximal LAD lesion, but of course, in those situations, you have to stent back into the LAD to ensure that you've got lesion coverage. And sorry, just remind me about your second question, Alfonso.
So why not fix the extensive dissection with two stent techniques as intention? I mean, after rotational atherectomy and flow limiting dissection, I mean, you were very confident to recross the left circ, but of course, it is not 100% the case.
Yeah, so I mean, this was obviously going to be a very time-critical maneuver here, and we had to make decisions very, very quickly over this course of a couple of minutes because we were about to lose this gentleman, unfortunately. The only technique which would be useful in this sort of setting, I guess, would be an SKS, and you could do that technically through a 7 French guide catheter, or well, the only way to do it would be to have one balloon, one stent, and then switch. Through an 8 French, it would certainly be possible to put two large stents down. But what I didn't share with you was that actually we had quite a lot of difficulty putting this stent into that left main LED complex. Despite having done the rotablation, I then had to do balloon inflations within that LED quite extensively because that stent was not really going down. I just didn't have the time to be able to do a 2-stent procedure then at that stage.
Okay, so thank you very much. Questions or comments on this case?
Yeah, here Lucio from Argentina, Alfonso.
Please, Lucio.
A comment. First of all, thank you, Dr. Khan, to share this complicated case, a particular left main PCI or ostial LAD lesion. First of all, a take-home message for more than 700 people that are showing us now. If you have eyeballs or an image, try to use from the beginning. there is two different scenarios. If you have images or don't imagine in this type of case. If you have images, try to use from the beginning. If the IBUS didn't go ahead when you start to, because there is a lot of calcified plaque, in this case in the ostial LAD, try to do a non-compliant balloon and Apollo non-compliant balloon to pre-dilate and then to assess by IBUS the LAD, the diameter, the calcify, if 360 or it's an eccentric, 180, where? Which is the size of the LAD? Which is the size of the ostium? Which is the size of the left main? So with that information, you can go ahead and perhaps you can go with a burr at 0.5 and not at 0.75, and you can prevent the dissection. That will be one. But perhaps with the calcification that you have, you can go with a non-compliant balloon, and that will be good in an 80 years old with a circ, left main, circ, dominant one. So in that case, perhaps you can do simple, a very complex case. In a situation, if you don't have an IBUS, perhaps you can have to go from, I will approach with a 7 French, 2 wires, try to pre-dilate with a non-compliant balloon. If I don't have IBUS, for example, I used to use stem boost. So I saw the non-compliant balloon if the balloon is well expanded or not. If it's okay, I will continue with the angioplasty. If not, I will have to try to do a better preparation plaque. But so there are two scenarios, IBUS or not IBUS. If it's IBUS, I have a lot of information. If I don't have the IBUS, I will do, and I will use another tools as a stem boost with a non-compliant balloon, or if not, with a rota, but with a burr from less to more aggressive one. And then what you say, Alfonso, after the complication, and what Dr. can do, first of all, to try to do a first attempt from left main to LAD. But if you think that the circ is too important, or it will be very, very complicated to recross, perhaps you have to put a stent first of all from the circ and then to finish from left main to LAD. But this is the situation that Dr. Khan have in that moment. So perhaps I used to do a lot of drug-eluting balloon and to do a one stent from the beginning. But in this complication case, with the patient with the pressure going down, blah blah blah, I think that perhaps in this case, with the complication, perhaps we can do 2 stent technique, but not from the beginning.
Yeah, I agree. But well, at least the final result was great. The patient was fine, and the day after he was discharged. So congratulations again for this very nice demonstration. Of course, imaging would have helped, but probably the prop would have not passed across the lesion because it was very tight. But sometimes even a small predil would have been of help in order to, well, have a nicer view of the plaque and then decide for the bulking device to be used. But again, the final result was fantastic, and the patient was fine, and that is the most important aspect. So we can move forward with the next speaker, Lucio Padilla from Buenos Aires, Argentina. The title of his presentation is Mastering Complex PCI with Novel Tools from BrosMed. So please, Dr. Padilla.
Sorry. I don't know why the presentation is
Starts from the end.
Yeah, I don't know what, but we will
No
do it.
worries, no worries, no worries.
So thank you very much for the invitation. The idea is to say why, when, and how to use POT in complex unprotected main bifurcation PCI, and how to improve the unprotected main PCI success with POT. So the idea is to show, we have been talking about, but the left main, they are not similar. There are a lot of different left mains. So this Big Mac is different as the other one. And so all the unprotected main PCI are feasible, but we have to choose the correct technique and material. That's the first information. And why POT in all the bifurcation lesions? So to achieve the full apposition of the stent in the proximal to the bifurcation, and to correct the underexpansion stent that we have a lot of times, to facilitate afterwards to access to the side branch, but any device, a wire, a balloon, a stent, and to correct the final stent deformation following the key. So we have showed this. What about the European Bifurcation Club consensus that says POT is recommended as a mandatory step in bifurcation? So it's very important to put the distal point of the balloon, and we have here 3 diameters. So we have to choose, first of all, the diameter 1 for me is the distal vessel. So if here is 3.0 and in the left main is 4, we have to choose the stent from 3.0, and we have to do the POT after this diameter that is in the left main. So we need to do, after we implant the stent, the correct POT to recross and to do the optimal optimization treatment of the stent. So with a regular balloon, perhaps we can have the latest of the distal mark, and we have 3 millimeters here, and we don't do the correct redilatation, or perhaps we can have a lot of carina shifting. But with this balloon that we have very short shoulders, 0.6 is difference. So we have shown this in different presentations that you said. Here we have in the left 3.2. This is too proximal, and the correct shoulder, as you can see before, is this one. So we need, this is too distal, we are dissection or doing a carina shifting there. This is too proximal with the stent, so this part of the stent will be underexpanded, and this is the correct shoulder that we have to deplate. I'm going to show for the people who is trying, or perhaps they don't do, and one of the questions is how many we do proximal optimization treatment, and what is POT is POT, because this is what we try to do, to put the implant from LAD to CERC with 2 wires. Then we have the POT, the first POT. Yes, you can see the shoulders here. Then this is what is correct in the center, but it is too proximal, this is too distal. So we have to move, and we have to accurate where is the position of the balloon to try afterwards to recross and to go to the CERC in this point, to do the POT, then to take and to rewire from LAD to CERC, and to CERC to LAD, and then to do the first sequential kissing, and then to do the second POT. And this is what's our reality. We have 22% on the bifurcation from the Latin bifurcation registry, that nowadays we have more than 1,400 patients. This is a sub-analysis from 200 patients. And what about POT? Provisional stenting we do in 62%. IVUS, 56%. Main vessel preparation, 90%. Side branch preparation, 45%. Look at this. Only 60% of the patient with POT is POT 22%, but it's not 100. So what about the technique? Provisional stent is this. In the provisional stent, we do, and finally do 2 stent technique with decay crash in 40% as a main technique. And what about this? Is the patient that shows Dr. Khan, a 9-year-old male that came here in my institution with a moderate aortic valve stenosis, with abdominal aortic aneurysm, with a good left ventricular fraction, but he have ischemia. And after the elective admission forever, the patient stay with angina, so we have to do this angio. And this is the angio of a 90-year-old. We can see here the left main calcified with a very low flow in the LAD. Here we can see again, what about the left main, the LAD, and what about the circ? So this is what we have. I'm going to stay here, as you can see. And as a summary, we have this. And distal left main, calcified plaque, proximal LAD, disease, subtotal circumflex. So the idea is we have a very good collateral flow from the right, epicardial one. And the idea is how to approach this. So I will show with this and with this, what is the approach. This is a circ of 3 millimeters, LAD 3.5, 5.5 from a left main. So the idea is what I try to do every time is, which is the vessel diameter, here, 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 the vessel angulation of the circ, in this case, the plaque characterization, calcified or not, soft, only soft, and the side branch access difficulty. So these are the 4 questions that I have to consider. This patient wasn't for surgery, it was only for us, for interventional cardiology, for the definition criteria. It's a very important or complex case. And the strategy, radial approach, 100% of in my institution, 90% of the cases, radial approach. Glide sheet slender 7 French, wire both LAD and the side branch and circumflex. Try to do the best plaque modification over the main vessel and the side branch. 2-stent technique, because I don't want to be having problem with this circ. I was guided PCI to know, and specific material as the pot technique and pot balloon. So here is the case. I try to go after the LAD to the circ. I choose first of all a choice, a BMW, a run through floppy, and then with a filler XT, I can go to the circ with a lot of difficulty, but this is the situation. So first of all, predilatation, no compliant Apollo balloon from the LAD, then to circ, 3.20, 18 atmosphere, try to see how the balloon is well expanded or not. And after, do the same to LAD, from left main to LAD. After that, trying to resolve. And first of all, I want to put the stent in the circ because I don't want to be having problems to recross there. So first of all, I try to go with a desk from left main to the circ with a mini crash, side branch here. So after I deploy with high pressure into a stent from the left main, I do the crash balloon 3.5. Here we can see I use a lot the stent boost technique, so you can see that we are in the correct position. So after that, I want to recross and go to LAD and do the first spot, as you can see here, with a 4.015 balloon, pot balloon. Then to do the kissing, the first, then to go to LAD and to leave at the final to the desk or drug-eluting stent from left main to LAD. This is the situation. And then we need to do the second pot, as you can see here, then to recross, then to relay to the circ and do the mini kissing balloon technique. And then to do the final pot with the stem boots and with the eyeballs that I didn't show all, but we have eyeballs from the beginning and to the final, and this is the final result. So complex PCI by radial approach is the election of choice in the daily practice. For me, left main PCI is feasible with very good result, but with the correct techniques and dedicated material as the pot balloon. And the pot technique is very important in bifurcation PCI because achieve full apposition of the stem proximal to the bifurcation, correct under expansion, facilitate further access to side branch with any device, wire, stem, balloon, blah, blah, blah. Correct final stem deformation following kissing balloon inflation or stem side branch dilatation. And the idea is that we didn't do in LATAM BIF 100% of pot in bifurcation cases. That is something that we have to take as a take-home message. We need to improve that technique or this technique in the bifurcation. So the idea is to discuss what do you think if you do in your daily practice in all the bifurcation lesions, the pot technique. I show you our result in the region in 1,400 patients. We don't do pot technique in all the bifurcation. What about one stent versus two stent technique? So that is the idea, but the take-home message is that if you want to do one stent technique or provisional stenting, in my case with DEB, you need to do a very good pot. Thank you.
Thank you very much. It was a very nice case, very educative for several reasons. So I just asked to Dr. Han, which is the percentage of pot performed in China? Do you have an idea? Or can you just give us some infos about your personal practice? Do you perform pot every case in bifurcation PCI?
Okay, thank you and for inviting to give some comment about the pot technique in China. And usually if we to treat the bifurcation lesions, if the main vessel has a relatively large size, is sometimes over 3.0, and we'll use pot techniques usually. And sometimes we choose the size of the balloon and compared with the vessel is 1:1, and the balloon not give some very high pressure, just very 8 or 10 pressure, and to change the deformation of the size of the proximal segment of the stent. But why should using the pot? Because the size of the stent and the size of the vessel is different. Usually, it's relatively smaller than the stent, than the size of the vessel. So we need the pot technique to change the size of the stent. And this patient is very interesting, and especially using the very small guide wire technique, which is the 回头望月 in China, and look back at the moon and use the guide wire and give to wear the circumflex for this patient, and very complex patient, and so guided by the IVRs and using the two stents to treat the left main bifurcation lesion. And I want to say, because sometimes we're using this for the first stent in the circumflex, especially when the angle up between the circumflex and the LAD is very large, nearly 90 degrees, and maybe even we're using the mini crush technique, and the stands will be in the longitudinal compression. and there's one layer between the stance and the office of the circumflex. And for me, according to my experience, I'm usually using the first the BLADE blade technique and the strategy to treat the bifurcation. And the B means, and I'll share my experience. And the B means the burden into the, because the plaque burden, and L means the plaque location, and A, the angle between the main vessel and the side branch, and D means date from the papers and some other and the centers, the E, according to the operator's experience. Sometimes we choose a very and correct strategy to treat the bifurcation is critical to get the good result for a long time. Thank you.
Great. So I think that POT is really very important in the setting of bifurcation PCI, because main vessel stent may deserve appropriate correction after side branch ballooning, and for this reason POT balloon inflation is mandatory in order to favor correct apposition of the main vessel stenting, but also it is extremely important the final position of the POT balloon, because this can impact significantly on final side branch obstruction. That's why it is very important to have proper materials, and in particular the POT balloon has a very short 0.6 millimeter shoulder, which can allow the operator a very precise inflation, even using some stent enhancement system. So to date we have many tools which can allow the operator to obtain a very optimal bifurcation PCI. So as Lucio said, could be very important to push the use of this technique in order to improve the results after complex bifurcation PCI.
Can I just add a comment as well? I think, great. By the way, Lucio, really enjoyed it. The other message that we have to get across is, of course, most of what we've been talking about has been left main stems, but in situations where you're stenting, let's say an LAD diagonal, you have to have enough stent back to be able to safely perform the pot. So even if you have a short lesion, what you have to ensure is that you have enough stent coming back beyond the bifurcation to be able to safely do the pot. Now, the nice thing about the BrosMed balloon is, of course, that you only need 6 millimeters to be able to safely perform that pot. The other balloons that we have available aren't always that short, and certainly when we've been looking for other short balloons, they're not often available. So you have to just be cognizant of that.
Yeah, fully agree. This is a very important comment. So not only the short shoulder, but also the length of the balloon is really very important to manage every kind of bifurcation in order to perform a perfect or almost perfect pot. So thanks a lot, Lucio. Very nice case and presentation. So we move to the last presentation. So the speaker is Dr. Şevket Görgülü. And the title of the presentation is Pronavi in Retrograd CTO PCI and Vessel Preparation with Wedge Non-Compliant Balloon. So please, Şevket.
Okay, thank you, Alfonso, for the nice introduction. I'm just trying to open the slides.
Yes, take your time.
Yeah, okay, let me see. So now I think I have the full screen, isn't it?
Yeah. We can see it.
So, thank you. So, before I begin with my speech, I would like to thank BrosMed for including me to this event. So, I have been doing a lot of CTO cases, over 300 per year, and it's gonna be 600 if we also take into account the complex PCI. I'm doing around 600 complex PCI. So, According to that, the title of the presentation is Retrograd CTO PCI and vessel preparation with the Wedge and C balloon. So we have different microcatheters. We have turnpike spiral, turnpike bolt, and tonus are only for on-target usage with maximum pushability features. So of course, I'm using also Pronavi for antegrade purposes, but it impresses me more in retrograde. Mostly, we prefer the septal collaterals because of safety issues. Septal collaterals needs mostly trackability, crossability rather than pushability, which means low profile braided microcatheters. Pronavi is one of the low profile microcatheters one can choose in very virtuous septal collaterals. This is a live case. This was a live case I performed in a CTO meeting. It was a retrograde failure twice. I accepted the case for a third attempt. We tried several septals and even the most visible one, but then we had to switch again into the first, this one. You see that we have a connection there. We used a braided microcatheter. It was a 2-marker microcatheters, and after septal surfing, you can see that we will land in the PD. I will just try to fasten this. It was a long fluoro, and here you can see that our wire, that our silicon wire is in the PD, and you will see here the crossing. But sorry for this long fluoro story. So now we are in. So you can see that our braided 2-marker microcatheter has difficulty in crossing, and you can see how this microcatheter, it's a 1.7 microcatheter, French microcatheter, and you can see how it pushes the guiding catheter back into the aorta. So then here comes the Pronavi, and the Pronavi microcatheter will do it nicely. We have the trapping balloon here. The thing is, I have this, I want just to fasten the procedure. This is a long story for that. But I have to show you how the Pronavi will make its way to the portus collaterals. Now this is the trap balloon. We deflate the trap balloon, and after deflation, you will see this is the Pronavi 1.7, 150 centimeter length, and you can see here we are going here nicely into the PDA. Here we have the tip injection, and then we're gonna switch the wire with the Gladius wire. And if I can just make this fast, but I have this screen here, it's intervening with me, so I cannot make it faster. Sorry for that. It's a little bit boring, I know. Now we have the wire here. We will retrieve the microcatheter back, and then we will go into the right track. You will see here the Gladius will find its way into the retrograde track here. And then here we have our Pronavi. The Pronavi microcatheter is advancing to the distal part. And then we have here the antegrade dissection. We are preparing for reverse cart. I skipped this one. And then we have difficult, support problems. This is a guide extension. We were not able to go into this guide extension. What we did was we snared it. After the Gladius went into the aorta, we snared it, but it was a short Gladius, and the short Gladius, we couldn't release it, really. So we had to do some kind of additional maneuvers to get rid of this one here, to release the wire from the snare. And here you can see that our microcatheter Pronavi is going into the guiding catheter thanks to pulling it with the snare. And then you will see here how we release the snare. And the snare, we pulled the snare. Of course, the wire was coming with the snare. And then we put a balloon in front of the guiding catheter here and prep the wire, and then pulled the wire and released the snare. You will see here now it's coming. Here is the snare. You should never snare a short wire. Okay, that's some kind of motto in CTO PCI, but sometimes you have to. And this is one of these occasions I had to do it. And now I'm pushing the wire and the snare this is very dangerous. You know, if you cannot release the snare, this patient goes to surgery. But somehow we will manage to overcome this difficulty here. You see here, because we have trapped it at the proximal part, and then we pull the snare, and here we are now done. And with the change to an RG3, our microcatheter was already there, and this is the end result. So with the taking into account the design and construction of the microcatheters, there are 4 microcatheters available apart from Pronavi. They are all braided and designed for trackability and crossability. They are kink resistant, but not for rotation. You advance them in a linear direction by applying constant pressure. One can rotate Pronavi to some degree to increase pushability. Tip profiles and entry profiles are somewhat similar between braided micros. I don't have the benchmark tests comparing one to another, but I can say Pronavi definitely works. And here, this is when it comes to epicardial collaterals, my preference changes between micros with inner coils, like Corsair Pro XS, Mamba Flex, Turnpike LP, or micros with braids, like Caravelle. There is one important issue with the epicardial collateral. They are very tortuous and long. The microcatheter may fall short and not reach the antegrade guiding retrogradely. So we have recently published 2 articles indicating radial approach is better in terms of access site complications. In our era, people getting bigger, and in terms of height with longer arms, the guiding catheter is usually shortened in epicardial collateral crossing to gain extra length in favor of the microcatheter. If you do that with radial approach in such persons, and even go distal radial, you may not reach the ostium of the donor artery. So if you don't shorten the guiding catheter, your 150 centimeter long micro will not give you the chance to reach the target CTO artery as needed. So I have seen experts operators call the companies during the live cases to manufacture longer microcatheters. In this regard, Pronavi 162 centimeter long micro is unique with its length. So this is another case I would like to share with you. So this is a failed, the diagonal graft is failed here, and we have a left distal radial approach. Big guy, but we shortened the guiding catheter, but it didn't reach the ostium of the left main. So we proceeded without shortening. So ambiguous cap, saphenous graft occluded. The only option is this epicardial collateral here from the LAD distal to the diagonal. This is a big diagonal. The patient is symptomatic. So first interrogating the collateral tortuosity. This is Pronavi again. This is Pronavi 162. And here we have a tip injection interrogating the collateral. And it was not, we were not able to go around because we didn't have enough support. You can see the guiding catheter here. So we did an anchoring of the CX. Here we anchored the CX with a balloon, and then we were able to cross with the wire. And the microcatheter followed. And here is the distal cap, and we were parking here with the Pronavi is coming. You see how nicely it is going. It's 1.7 French. It's a braided microcatheter. You should advance it, giving constant pressure. And here it comes nicely. So after that, it was not easy to cross the lesion. It went always into the graft. You see here, it was a pilot 200. We are puncturing always the graft, and then we did the fresh gladius. With the fresh gladius, we were able to track the calcification. You can see here, it's tracking the calcification. And finally, we were landing in the aorta. And even this 162 centimeter long Pronavi, you see here, we are now in the aorta, and then the guiding catheter couldn't follow because it fell short. We had a distal radial approach, and we had a 162 centimeter long Pronavi. It fell short. We couldn't advance it further. So what we did was here we're in the aorta. We go in the guiding catheter, and here we did a tip into another Pronavi. Okay. So here you can see the gladius is going into the Pronavi, and what we did, this is the end result after going with the micro down, changing the wires, ballooning, standing, and you see how big this diagonal was. So this was another case. So this is another case. Again, with the Pronavi microcatheter, this is a CX CTO of the OM. Here you can see it. And we have this diagonal epicardial collateral going into the CX retrogradely. And after failing antegrade, you can see the Pronavi 162 again. Here we have a tip injection, and here we have to proceed with contrast injection. We cannot serve in epicardial collaterals, it's dangerous. But here what I did was I had to somehow serve because it was not easy. I had to trust my guts here, and you will see how it will jump and go into the into the distal vessel of the LAD. It was the Sion black, and I was a little bit anxious about some kind of perforation. You see here it's going in and out here, and this is the initial coming of the Sion black, and now here we are in, and it will cross nicely. Very sorry for this long flows, but I had to show that. So it was a very tricky road. Let me show you the distal part. Here we are now in, and the Pronavi will follow here nicely again to the distal cup. I will fasten, and here this is the Sion black again. This is the Pronavi, and we will cross the CTO at the epicardial collateral and the CTO at the same time. You will see it's going up into the CX at the proximal left main, and you can see the Pronavi is very nicely following the wire, and the Pronavi is crossing the CTO and the collateral. So this is the Sion blue. We didn't want to damage the left main, so Sion blue we went with a workhorse wire. It will go in, and then after going in, you will see here it's now in the guiding catheter, and then the microcatheter will follow. I'm just trying to squeeze my presentation. I don't want to be long with my presentation. So now what we did a tip-in. This is a balloon. We squeezed the Pronavi microcatheter and made the rendezvous technique with Sion black antegrately into the Pronavi retrograde microcatheter. You will see this. It will come. It will take a while, but now we squeezed and we tried. It was not easy, and now we are not in. You can see here, and let me see here. Here we should be in. Took us time. Sorry for that. And now we are in. What we did was we retrieved our microcatheter back and then walked over the Sion wire. And here's the end result, ballooning, and you can see how big the OM is. So this was the part about the microcatheter. So I will give you a short look about plug modification, because I am not only doing CTOs, I am also doing complex PCI, and the Wedge NC balloon has a big role in my complex PCI work. So I would like to give you some examples about that also. So modifying the plug is very important in calcification before the drug eluting balloon usage is very important. My work has been very smooth since I used the Wedge NC balloon, and it feels like the trick is it feels like a conventional good balloon, and it performs better to its counterparts. You know, it performs better in terms of crossability. If you compare it with the angioscope or with the other, it's better obviously from the cutting balloon because it's bulkier than this balloon here. So I just wanted to give an example here. This is a calcified lesion. We wired the diagonal here, and we have slow flow on the LAD. What we tried to do is we couldn't go with the OptiCross IVUS microcatheter. We wanted to do an IVUS, but we couldn't do that. We did a 1.5 balloon dilation and then tried the IVUS again. No IVUS passage. What we did was 2.5 30mm Wedge NC scoring balloon. We went with that balloon through the calcification. We couldn't go with the IVUS, but we did this with the NC Wedge balloon. So you can see now we have the IVUS coming, and you can see here we have some cracks here. We have a crack here. This is an NC balloon, has a scoring material over the balloon, and I don't know. I'm not sure that this cracks is due to the Wedge NC because I couldn't beforehand send my IVUS, but it seems like it has the same appearance when I'm doing the cutting balloon. So I think it was due to the Wedge NC balloon. And here we have a dissected segment. It makes good dissection, but it's a controlled dissection. And if you have such kind of dissection, you can sand your stand easily down. And here you can see the IVUS images afterwards with good opposition. And this is the end result. This is going to be my last case. And this is in CTO case. We went through with the ultimate bros, and then we did IVUS. And at IVUS, we saw that the artery is 3 millimeter in vessel diameter. Okay, so then what we did, what was a Wedge NC, we did aggressive predilation with this Wedge NC. What we did afterward was we used only drug-eluting balloon. Okay, so this is the end result here. Without stenting, we managed to leave the vessel without stenting, thanks to the wedge balloon, NC wedge balloon, and the drug-eluting balloon. So here I would like to summarize my speech. In septal collaterals, Pronavi is a good alternative. I can say that. And in epicardial collateral, the strength of the microcatheter is that it has its 160 centimeter length. Okay, this is a very advantage for me. And when I want to say about the plaque modification procedure, so the Wedge NC is very useful in calcified lesions in terms of plaque modification, especially when you have in mind using drug-eluting balloons afterwards, because I think that it has a controlled dissection. It's not creating a mass of the artery, but it's a controlled dissection. And so after the drug-eluting balloon, you will have a nice result. Thank you for your attention.
Thank you very much, Şevket. It was really a great presentation, fantastic cases from a very experienced CTO and complex PCI operators. You highlighted nicely the features of the Pronavi and of course also of the Wedge NC balloon. So I asked to Dr. Han if he has some questions or comments.
Because of the limitations of time, and just give a briefly in the comments about the CTO and for these several interesting cases and the use of the Pronavi microcatheter, and for the procedure of the CTO PCI, maybe, and we'll have to prepare all kinds of tools for the procedure use, and especially the microcatheter. And I think according to the several cases have proved that the Pronavi microcatheter is very useful in the CTO PCI, especially for the retrograde technique. This one. And as for the Wedge balloon, I think I have much more experience using this balloon about coding this several and interesting cases. I think the Wedge balloon is the crossability is very excellent compared with other balloons. So I have no other comments. Thank you for your presentation.
Are there other comments or questions from the speakers?
So yeah, I just want to say about the NC wedge balloon here. So this is my primary tool nowadays, and I have used all the plaque modifying balloons on the market. You know, I've used the Flexstorm is not available anymore, but I have used a lot of Flexstorm. I have used the Wolverine. I have used the Angiosculpt. I have used the scoring brom from Orbis Nike, Scoroflex, I think. And I don't have one-to-one benchmark tests, of course, but from personal point of view, I can say that the crossability is amazes me a lot, you know. So because if you have a calcified lesion, you don't have the opportunity to go there with sometimes with normal workhorse balloons, you know. But even in that cases, very useful. So that's what I want to say.
Yeah, I fully agree with your comments. The trackability of the wedge and C balloon is very nice as compared to other scoring or cutting balloons in particular. But I have a question for you. For which kind of calcified lesions do you suggest the wedge and C balloon? For every kind, or do you prefer to use it in specific subset of calcified lesions?
If I have a heavy calcification, which means according to the classification, if there's a railroad, okay. If there's a railroad, you can see even without giving contrast. So if you have that kind of calcification, and if I have difficulty passing the IVUS, then I would definitely go with Rota. Rota is my first choice. But if I have moderate and less calcification, and if I have IVUS on the table, if I have the opportunity and I have the option to pass the IVUS through the calcification, and then I would decide according to the degree of the calcification. If I have more than 270-degree calcification, if it's not a ring, even if it's a ring, okay, even if it's a ring, I have seen that Wedge NC is working. But if it's a ring, then I would prefer more with the rotablation in such cases. If the degree on IVUS is more than 170 degree, I would definitely go with the Wedge NC balloon. But sometimes I don't have the IVUS on my reach, okay, at my disposal. It happens sometimes. Then I would seek for some kind of moderate calcification, which means that you have, after giving the contrast, you see the you know what I mean, the calcification, the calcified plaques, the effect. Then I could definitely directly, if I have moderate to low level calcification, low level to moderate calcification, because if I use the NC wedge balloon, if I do a good plaque modification, then I don't need any guide extension, okay, to bring my stent downwards. So that's and in that cases, I have also the opportunity without damaging the artery too much, going out of the procedure without even putting a stent there. So therefore, my threshold is very low. If I see low to medium kind of calcification, I go definitely with the Wedge NC. So I have a low threshold to go there.
Another comment,
Yeah,
maybe.
of course. Yeah.
For me, you have two strategies. If you have imaging IVUS OCT, this is IVUS guided PCI, precision PCI. If you don't have imaging, you have to do from no compliant balloon, stent boost guided PCI. No compliant balloon is not well overexpanded, scoring balloon. Scoring balloon is not well expanded, IVL. That will be my route.
Yeah.
So last thing, I totally agree, but there are some colleagues, they are not a fan of using scoring balloons. They try to first open the artery with non-compliant balloons and going with high pressure, okay? So this is not my strategy. If I see some kind of calcification, I go up front with scoring balloons. It can be a strategy. I'm not against it, but it's not my way of doing things. So there are also high pressure balloons. I am not talking about high pressure balloons. I am talking about non-compliant balloons. And sometimes if they try to crack the lesion, they create some kind of perforation. So even the balloon is not opening. You have a dog bone effect or something like that, and then you go up and up and up. Sometimes you rupture your non-compliant balloon, and then you create a mass. Okay. For me, I have an operator have seen a lot of complication, and I've done with complication. Okay, I don't want to see any complication anymore because I am so fed up with the complication. I do even if the cost is going high regarding the procedure, I will always be on the safe side by using the materials necessary, like proper plaque modification with scoring balloons, cutting balloons, rotablation, IVL. Definitely, I agree to Lucilla. So I think that should be the message.
Yeah, fully agree.
But the thing is that not all the people, not all the the interventional cardiologists have imaging. This is a reality in the world. Not all the people can use IBUS OCT. So we have to say this is a reality in Europe, in China, in Asia, in Latam. So if you can use imaging, first of all, use it from the beginning, not at the end. If you can use, you have to go from the more simple to more complex, and to do the best plaque preparation before putting any DES. Never put a DES if you don't have a very good plaque preparation, and never use a DCV, a depth, if you don't have lesion residual less than 30%, no dissection no more than B, and TIMI flow 3. If you have a residual plaque of 50 and you use a depth, is a failed PCI. It's not because the restenosis will be because of the depth, because of bad preparation. So bad preparation, and perhaps we need to compare no compliant balloon, a very good one with the scoring, and to say, what about the advantage in this type of plaque, no? Osteal lesion, calcified plaque, bifurcation. So this is an issue that perhaps we can do it.
Yeah, thank you. Fully agree. So I also agree on the point that imaging is not available everywhere. So if available, it is optimal to perform it in order to decide the best the bulking device, balloon-based or atherectomy device to tackle the calcified lesion we are faced with. On the other side, in case of imaging is not available, of course, a step-by-step approach, starting from an NC balloon, then cutting, scoring, or other devices is, of course, even very useful. So if you agree, we can conclude this wonderful webinar. Very nice presentations, very nice topics. So we discussed about bifurcation PCI from ACS to complex left main PCI, concluding to complex retrograde CTO PCI. So we and you highlighted the importance of operator experience and proper materials. So both aspects are extremely important in order to perform a successful complex PCI. So finally, I would like to thank all the speakers for sharing their presentations, and BrosMed to allow us to discuss and share nice cases, nice experiences, and useful novel materials which can help us as complex PCI operators to perform successful PCI. So thank you very much, and hope to see you soon in the next future. Bye, guys.